Hi, Cam followers. Sorry we're a little bit late this evening. You can blame Hannah for that when she's next live. We got very confused because of British summertime and the time differences. So I do apologise. That is completely Cam's fault, I'm afraid. But we are so excited and extremely lucky to have the amazing David Dycus here, and he's going to speak to us today all about the post-operative rehabilitation of our patients that have to go under sort of bone surgery, or we would call it orthopaedic surgery. So I'm going to pass over to you, David, if that's okay, so that you can tell everybody about your amazing self and all your brilliant achievements. I have put the logos of these are both your David's involved with both of these companies, but I'll let him speak about that a little bit more.
Oh, thanks so much. And I'm very happy to be with all of you this evening in the UK. Here it is just after lunchtime in the US. So we did get our times off just a little bit. But I'm David Dycus. I am a board certified orthopedic surgeon. I practice orthopedic surgery in Baltimore, Maryland. So that's on the East Coast of the United States. And I've been doing that for about a decade now. I also have my certification in rehabilitation. So I currently am the chief of orthopedics at the Nexus Veterinary Bone and Joint Center. I'm also the medical director of Nexus Veterinary Specialist. And then along with a human physiotherapist, Dr. David Levine, he and I run the Veterinary Sports Medicine and Rehabilitation Institute, which is an online learning platform really for all things rehab and sports medicine. And then as far as other things I do other than just clinical medicine, I do a lot of lecturing and teaching all over the world in the area of orthopedics. I have a big, heavy focus from a research standpoint in osteoarthritis. And then I am responsible for doing research, writing book chapters, editing textbooks, a whole number of other things that keep me super busy.
Yeah, so let's head straight on to a little bit about orthopedic surgery and what the current advancements are in this area. So it might, I don't know how you feel, but it might make more sense to go through each joint. So should we start with hips?
Yeah, sure. I know everyone is familiar with this term hip dysplasia, and it can sound like a scary term, but to really break it down, what it realistically means is that there's abnormal conformation of the ball and socket joint. So when we have a puppy, that means that there's laxity. So the ball is kind of bouncing out of the socket a little bit. And that's creating some abnormal wear and tear on the cartilage. And so when the cartilage gets damaged over time, there's going to be the development of osteoarthritis. And so as far as advancements go, if we are able to see these dogs when they're very, very young. So in other words, when they are anywhere from about 13 to 16 weeks of age. And if we can identify that they have hip laxity, we can do a very minor procedure called a JPS, and that stands for juvenile pubic symphysiodoesis. So it's much easier just to say JPS. And that's where we prematurely fuse part of the pubis, and that helps improve the ball fitting into the socket a little bit better. For years and years and years, we would always think of doing hip replacements in old dogs because we took the same philosophy from the human side of things. Realistically, I would, as a surgeon, rather put a hip replacement into a younger dog. So probably one of the biggest advancements when it comes to hips is the ability for us to do hip replacements in dogs starting at about 10 to 12, 13 months of age if they need it. Now, that doesn't mean we can't do a hip replacement in a dog that's older, that's skeletally mature, we can absolutely do that. We've come a very long ways when it comes to the hip. As far as hip replacements go, dogs tend to have a very, very good outcome. They tend to be very comfortable when it comes to hip replacements. Right now, from a joint replacement standpoint, that's about the only joint where we have continuously good outcomes and expect a almost normal return to function.
Yeah, and shall we move on to stifles, so knees, and talk about cruciate and the new things that are going on with that?
Absolutely. So cruciate ligament injuries in the dog, we call it a CCL, versus in a person, it's an ACL. And typically when we think of ACL tears in people, we're thinking of football players and basketball players, runners, skiers. There's a big traumatic event. Versus in the dog, it starts to degenerate or break down over time. So it's considered more of a disease process. And so it's going to be one of the most common orthopedic issues that we see. And we've gotten better at diagnosing these in the earlier stages of things rather than waiting until we just have a full blowout tear. And what I mean by that is really starting to pay particular attention to when a dog gets up, if they're stiff and they're sore, if they are sore after activities, or maybe they're at their water bowl and they're starting to lean and take a little bit of weight off of one of their back legs. We can use what's called arthroscopy, where we take a little camera and put it in the joint in a very minimally invasive way to see these tears when they start out very early. And I think that gives us the ability to do something surgically. And there's a lot of different surgical procedures out there to help stabilize the knee. And the whole goal is to try to slow down and minimize progression of arthritic changes, because in the case of tearing of the cruciate ligament, that allows instability to occur in the knee, which means that the cartilage is being rubbed atypically. And over time, that will result in osteoarthritis. So our goal there is to try to stabilize the knee, so that way we can minimize and slow down those changes. And I think if we can recognize it very early and intervene rather than waiting till later, then we're going to have a better long-term outcome.
Absolutely. And the next joint I want to talk about is elbows.
Yeah, elbows are still a really crummy joint. It's one of these, we've looked at a number of different things. We've looked at putting a little camera in the joint and just kind of cleaning up a little bit, removing little fragments. We've looked at cutting various portions of bone, whether it's the humerus or the upper arm bone, or we cut the ulna, one of the lower bones, to try to improve the fit. And, Professor Noel Fitzpatrick probably says it best, where it's really basically a poor fit. Think about the horse and the rider and having that good fit of the saddle. And if your saddle isn't fitting well, your bum's going to be sore. And it's the same way. We have based all of our decision making on how do we improve this fit to make it better. The problem is no matter what we do, they're going to go on to develop pretty severe osteoarthritis. And the elbow is not a very forgiving joint. It doesn't respond well to something abnormal. And so we're still kind of holding out for that, thing that is going to significantly change the game. Unfortunately, elbow replacements tend to have quite a high complication rate associated with them. There's partial elbow replacements we can do. We've started really going towards a lot of various what are called intra-articular injections, so where we inject something into the joint, very similar to what they do in people, and sometimes that's something similar to cortisone, or we could go down this avenue of what's called biologics, where we talk about things like platelet-rich plasma, and we could even dabble in some stem cells there. At least in the US, there is a new product that's a radioisotope that actually will help minimize inflammation in the elbow for about 9 to 12 months. And then I believe in the UK or in Europe, you guys have just gotten the approval of a anti-nerve growth factor injection.
Yeah, Librela. It's a hot topic.
which I'm super excited about. Unfortunately, it's not approved in the United States yet. But many years ago, probably about 6-7 years ago, when this first came around, I was involved with catching up on a lot of this, and I thought it was going to be a great product, and then it disappeared. And so I was super happy to see it come back, and hopefully, if anybody's dog out there has received it yet, hopefully we'll be getting some great positive feedback on that. So I think that could be helpful.
We've had a number, actually, because we have our Holly's Army group with Cam, and a number of people have had their dogs have Librela, and I think the main concern has been stopping their dogs doing too much after it, because they suddenly feel so much better. But we haven't had. I'm presuming you're talking about Synovetin when you talk about the radioisotope. I'm not. I don't think we have that in the UK yet. Certainly, I haven't seen it in practice, in first opinion practice. But we have had Librela in, so that's exciting.
Yes, I'm hoping that by the end of the year, early next year, we'll get it approved in the United States, and we can start using that. And the Synovetin is great. I full disclosure, I'm on their advisory board, but it really is a nice product because it targets what's called the synovium, or the inner lining of the joint. And that's really where all the inflammation comes from in osteoarthritis. And so what it does is some of the cells that are responsible for the inflammation engulf this radioisotope, and it causes those cells to die, which then lowers the inflammatory response. And these dogs seem to be quite comfortable with it.
And I've just had a little question pop up from Kenzie Lang saying, in the US, do you use Synovetin for other joints and not just the elbows? And my understanding is that is true. It can be used in any joint. Is that right?
You got it. It could absolutely be used in any joint. From a on-label standpoint of what it was approved for, all of the studies were done with the elbow. And it's very interesting, at least in the United States, because each state can be a little different as far as what they will allow with the licensure. So, for example, some states, once you have that licensure to administer it, you can administer it to any joint. And then some states say, no, your licensure is only for this particular joint. So, so it can vary by state, but theoretically, we can absolutely inject it in multiple joints.
Yeah. And then I think the last joint I was going to focus on was the shoulder. Do you do much for shoulders?
We do.
Yeah.
We do. The nice thing about the shoulder is that it tends to be pretty forgiving when it comes to osteoarthritis. What we see a lot of are soft tissue type injuries. So what are called tendinopathies, where we see long-term chronic strains to some of our tendons that cross the shoulder joint. And then also there are some structures on the inside part of the shoulder joint that can sometimes stretch out. And we get this concept of what's called medial shoulder syndrome, where there's a little bit of laxity going on there. Probably the biggest thing that's going to cause arthritic changes in the shoulder is going to come from a developmental orthopedic condition called an OCD, where there's a little flap. And that flap causes some irritation to that part of the joint and can cause some damage to the cartilage surrounding it.
Yeah, so I don't know. I don't know whether people, general public, know what OCD is, but basically, if you have the sort of joint surface, and then I like to explain it and then the cartilage like this, you might have a little bit that's sort of flapping up and causing some trouble, basically. So that's what we mean when we're talking about that, if that makes some more sense to you.
That's absolutely a great analogy.
I'm always using my hands. I'm always using my hands when I'm explaining stuff. So we're making so many advancements with these developmental diseases, and it's really exciting. And we're hoping, certainly, and over in the UK at the moment, we're still playing a little bit of catch up in that a lot of people don't realise that we can do surgery so early on in these developmental conditions. So the hope is that we will come to the realization that actually something can be done earlier on, which can potentially influence that joint positively to prevent or certainly reduce the osteoarthritic change in that joint.
Yes, yes, you just hit the nail on the biggest head, and that is for so long we have taken what's called a retroactive approach,
Yeah.
meaning we sit back and we wait on there to be arthritic changes on an X-ray, and then we start trying to do something. What we need to do is take the paradigm from over here and shift it to over here, where we take a proactive approach. So with young dogs, we start doing things to recognize joint problems that could result in the development of arthritic changes. And if we recognize those, we say, first off, is there something we can do surgically to alter that course? If there's not, then we say, well, what steps can we start taking to improve our lifestyles to minimize and slow down arthritic changes, which means hopefully we avoid the need for pharmaceuticals, earlier in life. We can, take simple things such as just changing up the type of flooring that dogs are walking on, or start to tailor their activities of things that are going to be fun for the dog and the owner, but are going to minimize the repetitive concussive forces onto the particular joint that might be affected. And so I really try to get veterinarians to understand, start thinking about arthritic changes not as an old dog disease, but as an any age dog disease, and start thinking about, in these young dogs, is there something there that could come back to be problematic later, where we can go ahead and get ahead of the curve, for lack of better words.
Absolutely. And there's actually a really great comment by one of the owners that is watching, and they've said, how do you determine if a total hip replacement is appropriate? I have a 6-year-old lab who was diagnosed at 2 with severe hip dysplasia. She's quite active. She does rehab weekly and she's well muscled. She used to be a former sports participant. Is that something that you would now, with knowledge that we have now, because I remember even 6 years ago when I qualified, we were being taught that with dogs that had hip laxity, let it tighten up until they're at 2 and reassess, and then perhaps they might need a hip replacement at 5 or 6. But the thinking is now changing, isn't it?
Yeah,
is that right?
Yeah. The thought process is starting to change a little bit. So I really break it into 2 kind of categories. The first one being, do I have a young dog that is having some subtle issues, meaning maybe they're self-limiting, so they don't want to play as much, or maybe they're reluctant to want to jump, or those sorts of things, and they have hip pain on examination. Then I would absolutely say, okay, let's think about a hip replacement early. If I've got the young dog that's got hip laxity, but we stumbled upon it completely incidentally, and the dog has no pain, they have no clinical signs, then we're going to talk about keeping that dog as fit and trim and lean as possible, and getting daily exercise through daily walking, not running around in the backyard like a knucklehead. And then say, okay, over time, this may progress to where we have arthritic changes that cause an issue. So in the second group, the older dogs, if the dog is 6, for example, and has been doing marvelous, is still able to go outside and have a good time, their quality of life is not affected, they're not painful, they're not stiff and sore, then I would say let's do all the things from a conservative standpoint for as long as possible. Because there's the potential that even though there's arthritic changes present on an X-ray, it's not necessarily affecting them. But if we start to see those subtleties where they're slowing down, or they're reluctant to walk up the stairs, or let's say when on our typical walks, they're starting to kind of lag behind us, or maybe they're starting to sit down and not want to walk as long, then I would ask myself, is this dog in an osteoarthritis flare-up? And if they are, how do I get this under control? And many a times we can get it under control. Where I look at surgery is where we have the dog that is reliant on daily pharmaceuticals, that their quality of life is such that they're not able to do the things they were able to do. And all of our conservative attempts are failing at letting them get back to their quality of life. Then I would say, okay, let's do surgery at this point, because at that point, we don't want to have to get by relying on daily medications and cutting back on their walks in a 6-year-old dog that may have many more years of happiness left. There's no reason to subject them through that discomfort when we could just do a hip replacement. And once they recover, they'll be comfortable and hopefully off of medications.
And one really great point is early detection. Do you use sort of force plate analysis or anything like that for early detection?
So for me, at a referral level, I will rely on a few things. I love objective information. So getting either pressure sensitive walkway or force plate analysis is great. We take specific x-rays to look at laxity. So basically the ball should fit into the cup really tightly. And if we take these x-rays and the ball's sitting out here, that tells us there's laxity. Other objective measures that can absolutely be used in first opinion practice would be taking a measuring tape and measuring the muscle mass, the thigh circumference. We can take a little plastic instrument called a goniometer, and we can actually measure how far we can extend the hip back to see if there's a reduction in those angles. And then there's also forms that owners can fill out. Those are called clinical metrology indexes to kind of tell us, even though we may not perceive our dogs in pain, if we fill out the sheet and then score up the total, maybe my dog's actually in pain, I just don't realize it. And then for really early recognition, there's what's called a COAST form, which is a canine osteoarthritis staging tool, which combines a questionnaire from the owner. It combines the examination from the veterinarian and the look at the x-rays to put a score to say that this dog has arthritic changes and here's the severity, versus this dog does not have arthritic changes, but they have a underlying predisposition that they could develop arthritic changes. And we might make recommendations based on where they're at for that particular scale.
And then I just want to briefly, before we move on to the post-operative management, I just want to briefly touch on intra-articular fractures. So when we've got fractures that affect the joint surface that potentially alter, even when we're considering repair of those, are we getting the correct alignment? Have we got inappropriate joint healing? Is the forces on the joint potentially going to be altered and cause premature arthritis and all of that comes with that?
Yeah, that's a great point. So intra-articular fractures, meaning a fracture that goes into the joint, it's very, very important that when we go into surgery that we repair that fracture so that there's no steps or gaps in the joint. So for example, if the fracture is right down the center here, we want to repair it so that it's nice and congruent. We don't want to repair it such that there's a step or that there's a gap. And if we do, that's going to create abnormal wear and tear, and they're going to develop worse arthritic changes. And the same can even be told of fractures away from the joint. Let's say the middle of the shin bone gets fractured. Well, if we repair that, we want the knee joint and the ankle joint to be nice and parallel. We don't want to repair it such that the knee joint is at an angle and the ankle joint's at an angle, because that can lead to abnormal loading onto the joints, which can lead to arthritic changes. And so that's why sometimes veterinarians may really push surgery for fractures instead of trying to treat it with a splint, because the splint, we can't control how much of the alignment is going to be messed up or normal when that fracture heals, versus the control we have when we go in surgically. The same could also be true with obesity. If a dog is overweight, then they're going to be loading those joints with more force, and over time that can lead to arthritic changes because they're overloading those joints more than what they were designed for.
Absolutely. And I guess that moves us on to sort of salvage surgeries, and when we need to use salvage surgeries, why we might end up in that position. So things like when we have to fuse the joints or take the ball joint off the hip and potentially leave it without that's the things that I'm thinking about.
Yeah. So, when you're talking about, like with the hip, taking the ball joint off, that's a procedure called a femoral head and neck ostectomy. Some people call it an FHO. In an ideal world, instead of doing that, we would move away and do a total hip replacement. Of course, in a perfect world, every dog that needed it would get it, but sometimes there are things that preclude a dog from getting that. And so what that does is we remove the ball, that removes the source of pain, and we let scar tissue fill in. And I think the number one procedure that is absolutely essential for post-operative physiotherapy is going to be an FHO. But other joints that we might need to fuse, the joints in the ankles and the wrist are sometimes a little easier to do if we've got end stage arthritic changes where the dog's just in pain, even in the face of pain medications, or there's a joint that's unstable and so they're not able to actually put weight on it appropriately. Our larger joints, so our elbows and our knees and our shoulders, it's a little bit more challenging to do a joint fusion, and they don't tend to do quite as well. And plus, they're left with a permanent lameness. And so we really try to use that as an absolute last-ditch effort when there's nothing else that could be done and the dog's in pain, and we need to do something to resolve that source of discomfort.
And is there ever, someone's just asked, is there ever a situation where a dog might have previously had a femoral head and neck excision and then you would decide to then put a total hip replacement in if they were really struggling?
So that can be considered. What I would say is on the surgeon part, the most challenging total hip replacements would be one in which a dog's had an FHO. Because where we remove the ball in both of those procedures, the cut's a little different. And so sometimes it even takes making a custom total hip replacement. And so, of course, financially, that becomes very, very expensive. And so I've always tried to get people to think if there's any hope at all that a dog could get a total hip replacement, don't do an FHO, because it's very, very challenging to go from an FHO to it. It can be done. It's just very difficult. And the risk factor of complications goes up.
And then I've totally forgotten about patellar luxation, which is a major thing that we see in the UK. I don't know about you, but I see so many dogs just because of the breeding with patellar luxation that then causes arthritis extremely quickly because it's just actively rubbing in and out of that joint all the time. So we should probably just touch on that one, if that's okay.
Absolutely. Yeah. So patellar luxation, so that's where the kneecap will either pop to the inside or pop to the outside. And that's considered a developmental orthopedic issue. So it develops very shortly after birth. There's usually underlying bony abnormalities. So there's some degree of malalignment of the thigh bone and the shin bone. And so the kneecap lives in a little groove at the end of the thigh bone. Think about kind of like between your knuckles here. And the inside of that groove is made up of cartilage, and the underside of the kneecap is made up of cartilage. And so as that's popping in and out, that's creating a lot of wear and tear on that cartilage and will result in arthritic changes. And it's not uncommon at all when we do surgery on those. If we look in the joint where the kneecap's popping in and out on that little into the thigh bone, we can see an area where it's eroded away the cartilage. And so in dogs that have clinical signs of skipping or limping or stiffness or that sort of thing, we typically will recommend surgical correction to try to realign everything to get that kneecap right where it should be so it's not popping in or out. And also in dogs, it's proposed that if they have an underlying patellar luxation, it can increase their chances of tearing their cranial cruciate ligament.
Yeah, because just putting all the abnormal pressures on that joint is just rubbing all the wrong way. Right. Yeah. So that brings us on to post-operative care, which is why we're here tonight. And what you advise sort of post-operatively from a rehabilitation perspective for sort of each joint or each procedure that we've spoken about. Because the sort of old school advice has been strict cage rest, and I sometimes still hear that strict cage rest has been advised. And what is your take on sort of the rehab if we sort of go back through the joints? So we'll start with the hip again.
Yeah. So in a broad sense, the concept of putting them in a box, so putting a dog in a crate, doing nothing more, we're going to take that, we're going to throw it out the window. That has long since been gone. And the reasoning for that is for tissue healing, we know there has to be some sort of stress to the tissues. And so there has to be a balancing act of some activity, but not so much activity it causes damage. And for a joint in particular, motion in the joint is where the cells that make up the cartilage get their nutrition from. So if we have a dog that just sits in a crate all day, that's actually going to work against us versus trying to get an early return to function and getting motion in that joint. So it might be easier to kind of, rather than going through each joint, which we can,
let's do it how you think.
Yeah, it might be easier to say, okay, after surgery, what we want to do is there's going to be an inflammatory response. We just did surgery. I mean, if anybody out there's ever had surgery, you wake up, you get home, and you think, oh my goodness, what just happened to me? And it takes a few days to kind of bounce back, and then probably about 7 to 10 days before you start feeling a little bit more like yourself. So for me, when I send these guys home, I tell the owners the first 2 weeks are a lot of rest and relaxation. And what does that mean? Well, what that means is when the owner is at home with the animal, I want the animal up and moving around the house. But that's under supervision. So I don't want them jumping on and off the furniture. I don't want them racing up and down the stairs. So many of our pets tend to follow us around the house when we're at home. And so if your pet does that, I would be okay with them kind of following you around. Again, though, if we have a lot of tile floors or hardwood floors or slippery floors, we would want to get some like cheap throw rugs or yoga mats or something just to help give them a little bit better footing so they're not slipping. If you have a dog that doesn't like to follow you around the house but likes to dart all over the house, I even will have owners sometimes put the dog on the leash and put the leash on their belt. And so that way the dog kind of hangs around with them, because that way they're moving around a little bit. When an owner takes the dog outside, I want them to be on a leash at all times, even if there's a small fenced-in area, because what I don't want is their attention to get grabbed somewhere else and then the dog twist a turn or run. And then when the dog is home alone, that's when I want a more confined area. So sometimes it's a laundry room or a bedroom or a bathroom or a crate or a home office, just some place where the dog's not going to get themselves into trouble when somebody's not there. And from that point, those first 2 weeks are, like I said, are a lot of rest and relaxation. If there's a surgical incision, I'm going to have the owners from day one start ice packing the incision. And I'm going to have them do that for day 1, 2, and 3. And then beginning on day 4, so day 4, 5, and 6, I'm going to have them switch from cold packing to warm packing the incision. We don't want to use heating pads. Heating pads can cause burns. And so ultimately, I have owners get these little commercial cold pack, warm packs where they can throw it in the freezer and it's a cold pack, or they can put it in the microwave and it's a warm pack. And that helps with inflammation around the incision. It also helps with some of the swelling. And then beginning about day 3, I'm going to have the owners start doing passive range of motion. So in other words, they're flexing and extending the joints just to keep some motion there, very light and comfortable. They're doing a little bit of massage therapy and stretching. And we're going to do that for about day 3 to 5. As far as going outside, from the first 2 weeks, it's to go outside. The dog can kind of sniff around, meander around, but I want them on the leash to urinate and defecate. And that's about all we're going to do. Once we get to about the 2-week mark, if it's a front limb or a back limb, I'm going to assign owners various exercises to do. And these exercises really start out very easy, from just kind of weight shifting weight from side to side. It works on some stretching. So we do what are called cookie exercises, where we're using a treat to help stretch out their back and their neck, just to kind of help keep them loose. And then we're going to also start a daily walking program. And I think this is the absolute most important part of the recovery in the post-operative period. We start out very slow on level, flat ground, probably 5 to 7 minutes, and we try to add on 5 minutes every week. And the focus here is more on the quality, not the quantity. So I want the owner to control the pace, not the dog, because we know that if dogs are recovering from surgery or if they're injured, they're going to want to naturally speed up their gait, because it's easier for them to shift weight off of something and cheat. So we want to slow them down to a snail's pace. And what you really have to think about is, if this is a Labrador, for example, you can walk at a relatively normal, slow walking pace. But if this is a Chihuahua and you try to walk at your normal slow walking pace, the poor dog's trying to run to keep up with you. So you almost have to go heel to toe walking. I mean, painstakingly slow. And we're going to work on increasing that every single week. And then ultimately, once they get to a point, typically about 4 weeks or so after surgery, we're going to start walking up hills and down hills. We might start some uneven terrain. But also what's extremely important is at around the 2-week mark after surgery is where I would recommend we start formal physiotherapy. Because what is able to occur is, owners don't know how far they can push their pets, and of course nobody wants to cause discomfort or pain, and so physiotherapists are really trained how to push those tissues to promote healing, but at the same time build up muscle strength and minimize damage to the tissues. And so what we see as a result of that is these patients hit their benchmarks in recovery a lot quicker. They're much more loose. They're not as tense. They don't have as many compensatory issues. And it'll also act as an outlet of energy because what we're able to do in a controlled manner is burn calories and intellectually stimulate these guys because they're not able to go outside and run around wild and crazy because they're recovering. So instead of going home and the dogs, chewing up the walls and causing damage because they're getting bored, we're able to do things. And also what happens is it's really kind of parallel such that an owner would go see the physiotherapist once or twice a week and they would do things there. And then they would get prescribed home exercises that they're going to be doing every day with their dog that helps continuously improve. So that way, once we get to the healing point, the tissues are conditioned so that we can start transitioning into normal activity. And at that point, we start to see less soft tissue strains when returning to injury because the tissues are more conditioned versus if they've just been laying around the house for 3 months and then they go out to chase a squirrel. Well, those tissues aren't ready for that. And they're going to come up lame. They're going to come up sore. They're going to have continuous problematic issues. And so I think the biggest thing is finding this balance of a quick return to function, but a supervised, controlled return to function, meaning I want them using the leg as soon as possible. So if I do a cruciate ligament surgery called a TPLO, for example, I want that dog to be toe touching and trying to experiment to use the leg, if not the day after surgery, within the first 3 or 4 days. I'd still sometimes, even in the US, see veterinarians that say, oh, nope, don't go to physical therapy. That can cause a complication or an issue. And that is not true at all. In the hands of experienced and trained physiotherapists, they're not only not going to cause a complication, they're going to actually help prevent complications from occurring. And they're also going to be able to identify if a complication were to occur, because what they're able to do is they're seeing these patients every week and they know, okay, at this many weeks after this particular surgery, they should be looking like this. And if they're not, maybe there's something going on. Maybe I should send them back to the surgeon to be evaluated. And we actually have evidence to show that formal physical therapy not only doesn't cause a complication, but also increases the chances of a successful outcome when done in the hands of a trained individual.
Yeah, I think that there's a particular study, isn't there, on the stifle looking at if we don't get that return of range of movement, actually we have long-term restrictions and scar tissue that means that joint is just not.
You got it. The thing to think about is range of motion. So the movement that a joint goes through is directly related to limb function. So if there's a reduction in range of motion, there's going to be some degree of limb usage that is not normal. And the problem is once that scar tissue sets in and we start to lose that range of motion, it is almost impossible, if not impossible, to get it back. And so the best thing to do and the best advice is to maintain and preserve what's there rather than lose it and then try to gain it back. And unfortunately, by not doing physiotherapy, we tend to lose range of motion. And then again, we're playing catch up to try to get it back versus getting them into physiotherapy and we can maintain what's there and then build and end up with a better outcome.
Yeah, and I think you guys in the US are way ahead of us over in the UK. But I think we're starting to realise, because there tended to be a culture of everyone just threw all of their sort of insurance money or onto the surgery and didn't have that extra budget for any sort of rehabilitative work. But we're now sort of catching up with you guys and realizing the importance of this rehabilitation stage, and that the surgery is just the middle, and actually the return to function is much, much better if we have got the rehabilitation specialist, the physiotherapist, assessing the dog earlier on.
Oh, absolutely. Absolutely. And I think that what I tell owners is that the surgery is just part of this whole process. The physical therapy and the physiotherapy is also part of what we need for ultimate tissue healing. I would say the one thing that you guys probably have the advantage of us on is that many owners have pet insurance, versus in the United States, it's very rare that people have pet insurance. And so it does become sometimes difficult from a financial standpoint. And that's why I think it's important when you look at the bigger picture to say, well, if we spend a little bit more for all of this, in the long run, we might actually be better off than if we have an issue and then we end up in physiotherapy for even longer, or we don't get the outcome we want, and then we're spending more money on pain medications for life and all these other things. And so, even though the upfront now might be, oh my goodness, this is much more expensive, the long-term life of the pet, it actually might end up being cheaper because we're able to hopefully minimize the need for things in the future.
Absolutely. And I was going to ask you, is there any orthopedic surgery that you do where you do advise strict cage rest? Or is it
not at the moment. Even with fractures, my goal is to have them stabilized enough that if I'm concerned after surgery that this dog needs to be cage restricted and have nothing done, then that's likely because I didn't repair something appropriately. Maybe if there was a hip luxation and we put the hip back in without doing surgery and we put them in a specific type of sling, that might be one incidence where I would say, let's do nothing for the next 4 to 6 weeks, because we need to try to get scar tissue to help hold the hip in place.
Yeah.
But even in dogs that if I do some kind of surgery and I put them in a splint or a bandage, I'll still send them physical therapy and have them start doing some things with the splint and the bandage on, rather than waiting until it's off. So for me, it's such a big part of my recommendations. And even in some situations, I'll recommend starting with physiotherapy before jumping into some kind of surgery, depending on the situation.
Absolutely. It's really, really interesting. We've got quite a lot of questions. So do you mind if I sort of scroll up and go through some of the questions? There's been a comment asking that if you have a dog and you diagnose or you find hip dysplasia, does that alter the loading on the knee joint, making it more likely for them to rupture their cruciate if it isn't resolved?
Got it. And can you still hear me? I think my camera froze.
Your camera's frozen, but we can still hear you.
Okay. Okay. So what? Tell me one more time. What was the question again?
So do you find there is a correlation between hip dysplasia and if those aren't resolved, cruciate injury in the future?
Yeah, great question. I would say that there's not necessarily a direct link, but what I have seen numerous times is dogs that have hip dysplasia and hip osteoarthritis, where maybe it's more affected on the right side, and so they spend time leaning over and putting more weight on the left side. Then they come in with a left cruciate. They're overloading that side of the joint. So that is actually not an uncommon thing. I don't think the hip dysplasia itself increases the chances of them tearing the cruciate ligament, but I do think if they're spending more time on one side of the leg versus the other, that could absolutely put them at risk of tearing the cruciate ligament.
Right. Yeah. And then we were speaking about the patellar luxation and sort of either doing a trochleoplasty or some sort of surgery to prevent that luxation. And I know that you mentioned that if we don't address that problem, we're much more likely to have cruciate rupture in the future. And someone's just asked the question that even if we do repair the patellar luxation, have we put too much pressure on the cruciate already? Is the cruciate going to be weakened? Do we still have a risk of cruciate rupture despite repairing the luxation of the patella?
Well, I do think that any dog in general is already at a disadvantage to tearing their cruciate ligament, just of how common it is. What I would not do is recommend doing patella luxation surgery in a dog that has no clinical signs of it affecting them, for the sheer purpose of trying to keep the cruciate ligament from tearing. Because what I would say is I don't necessarily appreciate a lot of patients that I do patella luxation repair on coming back for cruciate ligament tears in the future. Now, some do. What I see more commonly are dogs that have had underlying patella luxations that have never caused them issues. And then they're 4, 5, or 6, and they come in lame. And they're usually not coming up lame because of the patella luxation. They're coming up lame because they've torn their cruciate ligament. Right. What I don't know that we could answer is, did they tear their cruciate ligament because they had the underlying patella luxation, or were they going to tear their cruciate ligament anyways? And I think that's probably a challenging question to answer. But I, again, would not take a dog that's got a low-grade patella luxation with no clinical signs and do surgery just for the sole purposes of trying to keep the cruciate ligament from tearing.
Right. And if you were in that situation where you did have patella luxation and a cruciate rupture, would you address both of those when you went to surgery as preference?
Absolutely. Yeah, absolutely. You know, the first priority is the dog's typically lame because they've torn their cruciate ligament. So my first priority is getting the knee stabilized, and that's typically through a TPLO. But while we're in surgery, it only makes sense to correct the abnormalities from a patella luxation that dog may have. And so I will tend to correct them concurrently together when I'm in the operating room, rather than staging them, because it only makes sense if we're already there. Let's just go ahead and fix it so we don't have to subject them to a second surgery.
Absolutely. And then we haven't spoken about metacarpals, and if we've got fractures there, what's your preference? Do you prefer to fix those, like pin or plate them, rather than splinting? And what's the post-op recovery of each option? What's your experience?
Yeah, so it's going to really depend on which metacarpals are fractured, how many of them are fractured, where they're fractured, and the size of the dog. So if there are multiple of them fractured, then I'll tend to lean more towards surgical repair, either using pins or very tiny little plates. If it's a very, very small dog, or the fracture's in an area where there's just not enough room to get the implants in there, then we'll treat them conservatively. What I find is if we treat them surgically, that means we can get out of a splint sooner, and they typically have a quicker return to function. If I treat them conservatively without surgery and they're in a splint, because it's very difficult to fully immobilize, meaning take away the motion of that joint, they tend to be in splints longer than most fractures. So the average fracture should heal in about 8 to 12 weeks if it's stable. Sometimes these take 16 or 20 weeks to heal. The interesting thing is sometimes in small dogs, they may never heal. They are what's called a non-union. And if there's only, 1 or 2 of them fractured, that can be okay. But if there's 3 or 4 of them fractured, then that can sometimes become problematic. And so I find that along with the longer duration for them to heal when they're treated conservatively, we're also having to come in and have the splint and bandage change frequently. And if any of you have ever had your pets have a splint or a bandage, sort of the pain associated with having it changed, but also the wounds that come along with it, because they'll get rub sores or they'll get areas of abrasion and that sort of thing that have to be addressed. And my whole take on most any fracture is, can I repair this so I can avoid any kind of splint or bandage? Just because personally I hate them with all the morbidity and problems that they can cause.
Yeah, absolutely. I had a patient recently, and he was hit by a car basically, and he had sacroiliac separation, and so it was lag screwed back in place, so his pelvis was reattached, and he had quite significant nerve damage, which led him to knuckling, and he was put in a splint, and it caused so much trouble. It was such a shame. It just ulceration around the top of it. It cut into his paw pads. It was just an absolute nightmare. We ended up just binning the brace entirely. So I'm definitely not a fan of them after that experience.
I can imagine.
Yeah. Is there any situations where you would recommend sort of a brace? Because there are sort of some quite nice neoprene ones for toe ups if they've got issues with their digits or any sort of arthritis in those digits, where they struggle to pick their paws up potentially.
Yeah, absolutely. I think for our neurologic patients that are dragging toe up, braces can help. Honestly, for me, for the smaller joints, so the wrist and the ankle, if there's a bit of instability or discomfort, the neoprene wraps work really well. Even getting custom braces made work really well. I've almost gotten to the point for some dogs, rather than fusing the joint, or if there's a long-term soft tissue injury or really severe OA, if I can use a wrap or a brace to keep them comfortable, I might even try that before I jump into surgical intervention. So the smaller joints lower on the limb, I think, do better. Where I think braces are not going to be appropriate and help us very much is when it comes to the knee, and we're using it for cruciate ligament management, because the brace itself isn't really actually stopping that abnormal motion or stabilizing the knee. What I think it's doing is it's probably slowing down the motion in time for the surrounding tissues to catch up and react. But for them to be effective, they've got to be custom made. These dogs really need to go through a rehabilitation program, and then they probably need to have a knee brace on for life. And I've always found it quite humorous that people will put dogs in a knee brace, and then they talk about how well the dog's walking and using it. And I'm watching the dog walk, and the dog is not even able to really flex their knee appropriately. They're just sort of limping along. And so I'm thinking, well, they're not really using it appropriately. This brace is inhibiting their normal motion. So I don't know how much good it's actually doing.
Absolutely. So we're coming towards the end. So can you do, and Hannah's asked me to ask you this, so tell me if you're up for it or not, a little 1-minute summary for each condition, the post-op expectations and care for each?
Yeah. So I'll start with the hip. Post-op expectation. So for a total hip replacement, the post-op expectation is for complete normal return to function. For an FHO, where we cut the ball off and we let scar tissue fill in, we expect improvement in comfort, but limitation in overall athletic ability. For the knee, if there's a torn cranial cruciate ligament and we do a surgical procedure such as a TPLO or a TTA, we expect a normal return to function. If we treat it conservatively, meaning without surgery, we expect a somewhat comfortable, good quality of life with their overall intensity, duration, and frequency of activity to be less than what it was. For the ankle, it really depends. If there's a developmental orthopedic issue and there's really severe osteoarthritis, the ankle doesn't really respond very nicely to abnormalities in it. In that case, if I can treat them with a brace or a wrap, I would expect improvement in comfort. If quality of life is so severe that we need to fuse the ankle, we could do that, but they would have some degree of a gait anomaly. For the shoulder, if there's a developmental orthopedic issue, such as an OCD lesion, where we go in and remove that little flap, I almost expect them to go back to normal function. The shoulder behaves very, very nicely for us. The elbow is our outlier of all of these, whereas no matter what we do, There is going to be arthritic changes. There are going to be flare-ups. There are going to be periods of stiffness, soreness, lameness over time. It is going to become progressive. So no matter how hard we try, unfortunately, we can make them slightly more comfortable, but we've got to recognize that they're never going to be normal. And the reasoning for that is if the elbow was never normal to begin with, we can't make it normal afterwards. And then the wrist is going to follow sort of the same suit as the ankle.
Yeah. And sort of metacarpals and digits, do you ever see sort of such severe osteoarthritis that you end up doing surgery to remove those joint surfaces or doing anything there? And what's the post-op expectations and recovery like if you do?
Yeah. So our metacarpals, metatarsals, if those are fractured and we can surgically repair them, I expect normal return to function. In some of those, if there's only one or two that are fractured and we treat them conservatively, I still expect those to return to normal function. As far as the toes go, if there's severe arthritic changes, we can amputate toes if we need to. Sometimes even dropping a little bit of cortisone in and around the toe joints can be quite helpful in improving comfort there. The downside is things like injections are going to be temporary. So I expect that flow, like any arthritic joint, where we're going to have periods of comfort followed by periods of flare-ups or exacerbation, and the goal being to do something to get back to that period of comfort.
Great. And we've spoken a lot about physio and how valuable it is. Is there any I mean, in your rehabilitation work, is there a place for laser therapy and any of the sort of the more adjunct therapies that we speak about?
Yeah. Absolutely. And so I have many soapboxes, and laser therapy is one of those where I think laser therapy can certainly be effective. But what we have to realize is that laser therapy by itself is not physiotherapy. It's a portion of physiotherapy. And so where we're going to have the best effect is when it's combined with other things. And so that may be therapeutic exercises, that may be the underwater treadmill, where we then follow up with laser therapy to spot treat some areas. Therapeutic ultrasound to warm up the tissues is excellent. One of the modalities that I absolutely love for arthritic management is what's called extracorporeal shockwave therapy. And the reasoning for that is that with laser therapy, for example, the effects of laser therapy are very short-lived. Versus shockwave, whether it's for an arthritic joint or for a soft tissue injury, we know from studies that after a treatment of shockwave therapy, the effects can last up to 90 days with improvement of the hip or the knee if they're arthritic on force plate analysis. And so what we see is a very long-term effect of that modality. So I think it's an excellent one that's very commonly underutilized.
And if you had an owner that was on a specific budget, post-operative, obviously we've done the surgery, post-operatively, what would you advise is priority?
So what I would tell them if they're on a budget is the focus on the at-home program. Meaning if we can't come into formal physiotherapy, we're going to start by improving comfort by teaching you how to do range of motion and stretching and massage. And then I'm going to have you start doing what are called isometric exercises. So a lot of the leaning, the picking the leg up, the weight shifting, and we're going to start very easy controlled walking. And then as we progress, we're going to get more advanced with our exercises. I might even have you put some couch cushions on the floor and have them walk on that, or blow up an air mattress and have them walk on that. I may have you take them and walk them on a trail where they have to work on stabilization of some of these smaller tendons. We may even go to the water's edge if you have the ability and kind of walk along the water's edge where they're having to pick their feet up out of the water and push through the current and that sort of thing. So, if we can't get into formal physiotherapy, there are things that we can certainly do because doing something is better than doing nothing. And what it takes is the dedication on the owner's part to commit the time each day to work with their pet, which I think most owners really want to do.
Yeah, I think that's a really empowering message, actually, that rehabilitation and post-operative rehabilitation in particular is so important. But that actually there are options available to us on every budget level. So you can have all the whistles and bells if you want, but actually we can quite effectively recover the animal as long as the owner is on this journey with us. And the realization that we might be asking you to do sort of certain activities or physiotherapy for life. Would you agree?
Yeah, there are certain things that it really requires owner participation. And in a perfect world, we'd be able to say, here's this pill, just give it daily, and you never have to worry about anything.
Yeah.
But in reality, it doesn't work that way, unfortunately.
Yeah.
And especially with an arthritic dog, what it requires is what I consider two parts. The dedication on the owner to do the daily exercises and our daily walking and maintaining a lean body weight and ensuring that we keep the joints in motion. And then during periods of flare-ups where things get worse and we start to have clinical signs, we bring in the formal physiotherapist to really help get the joint under control and get things comfortable. And that's where we might throw in some medications, where we might throw in intra-articular injections. And what's important is that we don't get frustrated knowing that, this is unfortunately the disease process where there's going to be periods where life is great and we don't have to focus so much, but then there's going to be periods where life isn't as great. And it's not because something's failing on our part of what we're prescribing. That's just the disease process. And we have to understand, okay, we're in a flare up. Let's take a step back. Let's get this under control quickly. Let's not ignore it. And then let's get back to where life is good again. And so it really does require a committed owner that's willing to put in the effort. And, unfortunately, if you have the owner that is not willing to participate in their pet's healthcare, then unfortunately I'm limited to what I can do. And we have to then really set the expectations appropriately, because the expectations are going to be very different if you're not willing to put a little bit of time and effort into it.
That's great. Well, we're so grateful that you came to talk to us tonight, and I'm so sorry again for the complete confusion over time. Is there any last points that you would like to add, or anything that you feel that I've missed?
No, I think this has been a great conversation. I hope it was informative for everyone. I always love being able to come on and talk with everyone associated with CAM. I think the whole process and thought process behind CAM is absolutely amazing. And so I'm honored to be able to come and chat. And I'm honored that people like to log on and listen. And then all of you should be very proud of yourselves, because you're taking the time out of your evening just to sit here and listen to me talk so you can learn more about how to care better for your friends at home. So we'll hopefully have another session in the near future on some other topics. And then if any of you out there are into social media, if you don't mind checking out my professional Facebook page, it's Dr. David Dycus. And then my Instagram is ortho_vet. So certainly check those out. I like to post various cases and various information on things. And again, a massive, massive thank you to everyone for tuning in and allowing us to have this great chat.
It's been so brilliant. And I don't know whether you can see the comments, because I know that we lost your video, and I'm so glad that we can still hear you. But everyone has been so grateful for your time and have really appreciated how much information that you've packed into the last hour to teach us some more about sort of the post-operative care of our pets when they undergo orthopaedic procedures. And we are very much looking forward to next week. Tuesday, we've got you again, haven't we? I must double check the time with you. But we're going to talk all about hips, aren't we, I think? So
I think we are, yeah.
For that. So from us, we're going to say goodbye now, and we'll see you again next week. Bye, CAM followers.
Absolutely.
Thanks for joining us.
Thank you.